Like, sir, or should we swap this?
Thank you very much, Amina. Should I call you Amina or Alaja? Which?
No, Amina. Titles are
well, just to say a little bit more, I used to speak Hausa quite well. I went to school not very far away from here in Barewa College, so that was many years ago, and so I over time I've forgotten most of my Hausa. But otherwise, you know, I know the proper titles, so I want to be sure that I use the proper titles. Thank you once again, and welcome to this panel where we're going to be sharing as much information as we can about what the foundation is doing in Nigeria. You've been exposed to a wide variety of us, but just before I go, I launch the session. Can you please just raise your hand if you come from the public sector? Two people, three people, four people. Well, is the reluctance to raise your hand because you're not sure who you work for? Or it's just the usual Nigerian shyness? No, the reason I'm sorry. Please pay attention to me. I'm surprised that we have relatively so few government public sector participants here, because I think our work is not just with the civil society organizations. Certainly when you're talking about scaling up an impact, you then get involved with kind of policies and regulations and kind of institutional arrangements that facilitate or impede that. And government is right in the middle of all of that. So I'm sort of a little bit uncomfortable that we are discussing among ourselves. You will know a heck of a lot more about us, but it doesn't help because they don't understand what it is we do, and probably they don't understand what it is you do either. So I think going forward, we will try to get a bigger balance, because we're talking about equity here, and government is an equitable partner in this process. So just one quick comment. Second thing is that each one of my panelists, and we've got a distinguished group of foundation panel here who have really deep engagement through their colleagues and importantly by themselves, because they've been here multiple times, not even talking about Mero, who's been here all the time, trying to make sense of all of this, to try to share with you the evolution of their thinking, particularly in their program area strategies, that will be important for you to factor into your thinking. I'm hoping that each one of them will make no more than 15 minutes of presentation. It's not just talking to you, but also that you will talk back. You've not been very good at that. Okay. This morning we were talking about the results of the evaluation of the feedback. We're talking about the feedback, and I mentioned about the 18 out of, at least in this room, I would imagine that we're more than 120 people. I mean, each table is about 8 or 9 people. We've got about 20 tables here, so you can work out the arithmetic yourself. And to say that only 18 people, and we're not actually sure whether all 18 are from individual organizations or there's 2 or 3 of them from one organization. We don't know how many organizations that captures. And we're talking about giving you an incentive to give us feedback. We paid for your airfare to come here. We put you in pleasant surroundings. We're going to feed you, believe me. If we start slow, doesn't mean you're... all we ask for is half an hour, the most, for you to give us some feedback. What do you want from us? What do you want? Or what incentive do you want for us to... You want us to beg you so that you can give us feedback? I will beg. I will say, jump down for my knees now to beg you. Because we cannot know what you're thinking unless you tell us. We don't have a mechanism for reading your mind. And it's easier for you to complain than for you to say, here is what it is you can help us to do so that we don't have to complain. Nigeria is full of complaints. There's always something we're complaining about. we're reaching out to you. We're making this facility year after year. Every year some of you come, next year will be another different group of people. We cannot continue the conversation the same way because we've got a new, those of you who were here last year, you raised your hand. I could count it on my finger. Is this the way you want us to interact? I think a relationship is a two-way thing. We're reaching out to you, we're trying our best. If we're not doing it the right way, let us know. But this business of us giving you an incentive to give us feedback, we've got to talk about that. That's not working out for us. Okay? So please help us meet us halfway. And in that way, that's just to start the conversation. There will be presentations, there will be a lot of things thrown at you now. I don't know how it's going to land on you. I don't want you to complain during lunch. I want to give you an opportunity here to feed back to us, which is why they won't say more than 15 minutes. But we're taking notes, believe me. And each one of these things that we come up with today, next year we'll come up, we'll talk about them again. I'm tempted to ask each of you to sign that you will show up next year at the same meeting, because it's a conversation that I would like to continue year after year, so we can track our progress. Okay, you are our greatest link to the people that we're trying to serve. Okay, we cannot know better than you how best to reach them. Between you here, you have hundreds of years of experience doing this work. We're saying, help us to structure ourselves better. The more we know, the easier it is for us to make the arguments to change some of the ways we work. But if we don't know, and if we keep getting smaller numbers of you expressing an opinion, it doesn't help us very much. Okay, having given you this, given us this background, I'm going to start with Carlos. Carlos is a colleague at the foundation. We joined the foundation about the same time. And we have very similar experiences. He's a field rep, just like me, in the sense that he's very comfortable out and about at the site where the work is getting done. But the integrated delivery team that he works with has a very broad mandate. And in Nigeria, more or less handles the coordination among the various health inputs that we have. So he's going to talk about their vision and the changes in the evolution of their thinking with regards to Nigeria, both regards to Nigeria, but overall, as time goes on. Okay. So, Carlos, could you take the table?
Thank you. Thank you very much. Good morning to everyone. My name is Carlos Cuellar. I'm with the Integrated Delivery Team. There are two definitions of the Integrated Delivery Team. One is for the external world, is the team that is supposed to address the system constraints to performance. For internally, integrated delivery is a team where the foundation decided to park complexity. So we are in a lot of, let's say, crossroads, and the integrated delivery team is a functional team that has the responsibility to interact with the different strategic teams that, or the so-called vertical teams. I will start by, I want just to give you an update and how what are we planning to do, or what starting to do in Nigeria. But I will start by trying to frame it and describing what on the equity issue. There are three main facts that affect the health market. The first one is that income is not related with, not distributed according to health needs. Do you agree with that? Sometimes it's the opposite. Most of the times it's the opposite. The more income we have, the less needs. Not always. Second, people cannot anticipate most of their health needs. You cannot say in 5 years, yeah, I will break one of my arms. You cannot. You cannot anticipate what's in the future. Maybe some preventive, yes, but most of our curative needs, you cannot say, I will get sick in November. The third one is that most people cannot judge the technical quality of the services they receive. And the poor are the ones that are most affected with these three facts. They are the ones who have less income, more health needs. They are the ones who cannot anticipate their needs in preventive because lack of knowledge, lack of awareness of some of the things that they can do in order to prevent either primary prevention or secondary prevention in their health issues. And third, they are the ones that are less prepared because of the knowledge gap to judge the technical quality of the services they produce. So the answer is not the market. I believe that the invisible hand of the market can solve part of the problems. If we let compete providers and suppliers, maybe some of this will be addressed. The second, but in addition to that hand, we need two more hands. Second hand is the strong hand of the government to regulate that market, to protect the users, to make sure that quality is there, to make sure that economy, quality, and ethics are working together. And then we have one pair of hands. We need one more pair of hands, the hands of solidarity and social protection, to address the needs of those who cannot play the game of the market. So it takes me to the theme of this important meeting, and we'll just want to remind what is in our webpage, the Gates Foundation, that all lives have equal value. And it means that equity is an integral part of the Foundation's philosophy, and I would like to take this opportunity to kind of congratulate the country office, the Nigeria country office and the Nigeria region for selecting this important theme. So these are the principles that are guiding our approach to primary healthcare strengthening in Nigeria. I think when we look at the statistics of Nigeria, something that is very clear is that the system is underperforming. We can look at the statistics and we can see that the trends are that the indicators are stagnant. And this is based on the DHS reports of the last 10, 15 years. If we go deep, if we dig deeper, we may conclude that this lagging performance is not a result of a blind spot. It's not because the public health community doesn't know what the problems are. I think probably Nigeria, all of you and many others outside of this room know exactly what the problems are. It's not a blind spot. It's not that you don't realize what the problems are. It's not also because of lack of efforts, because the government, both federal and state, they have been making a lot of efforts and working with local NGOs and working with other donors support. So efforts are being made. So this lagging performance, I think, is rather an indication that there are some deep, serious system constraints that are holding performance back. And that's the basis of our approach in terms of primary healthcare strengthening. In this slide, it's reflecting basically that we need to use, our philosophy is that we need to use multiple levers that are mutually reinforcing in order to address system constraints. And then you have some examples of what are those levers. Governance, somebody mentioned this morning about the importance of governance, performance management and accountability, health financing, including demand-side interventions that will favor or facilitate access to services by those who are most in need, the poor and the vulnerable. I just want to stress that this use of multiple health systems levers are influenced by certain principles, such as the focus on fewer states. We cannot afford to, we don't have the resources to act in all 36 states. We were trying, but I think we found that it's not working. We need to focus. We need to engage both public and private providers, or private sector. We need to have a program that is country-led. It's led by the government, with the government at the driver's seat, the country driver's seat, and with local grantee support. Our strategy is supporting what we call building the field, and building the field shouldn't be a word, just an empty word, but a very concrete concept of supporting local organizations as implementers, as partners and implementers. And also, we believe that it's a government and donor interaction with the necessary resources. Next one. So our investment structure, we have investments at the federal level and the state level. They are very focused. The central part of our intervention is our interventions at the state level. No? We believe that because of resources, but not just because of resources, because of scale. If we really want to produce change or transformation, which is a better word, and I think we need to focus at the state level. We have selected 3 states in which our flagship program called Partnership for State Primary Healthcare Transformation that will be implemented through the Health Strategy and Delivery Foundation, HSDF. And in addition, in support of this, we will have 2 federal investments, one in support, technical assistance in support of the National Primary Healthcare Development Agency, and support of demand-side financing through the National Health Insurance Scheme for those selected states initially. No? The idea is to use this as a platform for learning how we can, and probably respond to this question, how can we transform the primary healthcare system in one state, and then learn from there and go to others and disseminate the lessons learned and collectively engage into other transformations. And at this point, I would like to make a distinction between transformation and change. No political connotations. I know. Yeah. Let's put politics aside. Yeah? And that's the difference, I mean, the simple one from the, let's say, one, for us, for our, let's say, for our, in the context of our project, we believe, or our initiatives, transformation is when you elevate the performance, you improve the performance of the primary healthcare system in a way that is significant, It's not a gradual improvement. And second, that it's irreversible. It's like making a cake. You need eggs, you need butter, you need flour. You bake the cake. Can you take it back to egg? No. Then it's a real transformation. If you can take it back to egg, that's not a transformation. So with this silly example, what we want to say is what can we do in order to transform the primary healthcare system, elevate the performance of the primary healthcare system in a way that can resist the test of time, can resist the test of change in personalities, in a way that is irreversible or very hard to reverse. And that is, I think, it's an ambitious goal, but we believe that it's possible if we focus on fewer states, if we focus on key interventions that address the root causes of system constraints that are holding our performance back. Next. Yeah, this is the state program, PSC program timeline. We already identified 3 states, no? And the 3 states are Kaduna, Niger, and Nasarawa. And we already started with the diagnostic in Nasarawa, and we will continue with the other 2 states. We still have other activities in other states that, like Lagos. I think we will have some specific interventions focus on private sector and health insurance for the poor, but these 3 states will be the flagship for our intervention. This is, of course, doesn't preclude any other intervention from the foundation all over in other states. Next. Next. Yeah, these are the federal investments at the technical assistance at the National Primary Healthcare Development Agency, and also support of demand-side financing at the state level through with the support of the NHIS. I will just want to thank. That's it. I think my 2 minutes are over. And just with so many things that I have learned in Nigeria. One of the things that I learned in one state was that health is wealth. And I heard that so many people, then I heard it repeating, health is wealth. And I didn't know how to retort, how to reply to them and say health as well is wealth. Then my reply became this. Okay, think in the word illness. Illness. And then replace the I with the we. The I with the we. Illness becomes wellness. That's my message. Thank you.
Thank you very much, Carlos. We're scheduling 15 minutes for each presentation, and we'll have questions. I'm sure you have a lot of questions. I have some myself, but we'll hold them till the 3 speakers have spoken. We had time scheduled for 4 panelists, so we have extra time because the polio and the routine immunization folks are not able to be here.